My student. This is the chapter 4, part 2. The last lecture in the part 1 in the same chapter, we covered the three classes of lipids. Today, in this lecture, in the part 2 of the same chapter, we need to cover the how. How does our body, which is mostly water, possibly digest and absorb these oily insoluble fats? Lipid digestion and absorption and transport are complex but truly elegant process, driven by hormones and enzymes. Because lipids are insoluble in water, their digestion is far more complicated than that of the carbohydrates. Some minor digestion begins in the stomach, where the acidic environment activates a lipase. But the primary site of the lipid digestion is the small intestine. So, when fatty chyme means the food acid mixture from the stomach enter the duodenum, it triggers intestinal cells to secrete two key hormones, CCK, cholecytokinin, and secretin hormones. CCK is the main star. It signals the gallbladder to contract and release its stored bile. It also tells the pancreas to secrete its digestive enzyme, including the powerhouse enzyme pancreatic lipase. So again, secretin hormones is the liver produces bile. Pancreas release bicarbonate. CCK, the gallbladder release stored bile. Pancreas secrete pancreatic lipase. So what is the role of bile? Bile is not an enzyme. It acts as an emulsifier. The bile salt in the bile emulsify the lipids, which means they break down large fat droplet into a tiny microscopic particles. This emulsification is critical because it dramatically increases the surface area, allowing the water-soluble pancreatic lipase to gain access and attack the fat molecules. The lipase then cleaves the triglyceride into monoglyceride and free fatty acids. So in the next slide, I will show you the figure that provides a visual step by step of this crucial digestion process. Let's walk through this figure, which shows the digestion in the small intestine. First, here, you see the large fat droplets from our food. In the step 1, the bile salt, which were made by the liver and stored in the gallbladder, are released and perform emulsification. They break that large droplet into many small suspended particles called emulsified lipids. In the step 2, lipase from the pancreas can now access these small particles. Let's us to continue. In step 3, the pancreatic lipase gets to work digestion to the triglyceride, it chemically snips off two fatty acids, converting the triglyceride molecules into one monoglyceride and two free fatty acids. The last step, in step 4, the major end products of the fat digestion are glycerol, fatty acids, and monoglyceride. Now that these lipids are broken down into small components, how do they get into the absorptive cells of the intestine? This is the absorption phase, which also occurs primarily in the small intestine. The absorption process is different based on size. Look here. The short and medium chain fatty acids are small enough to be relatively water soluble. They can diffuse directly into the absorptive cells and enter the bloodstream according to capillary networks. But long chain fatty acids, monoglyceride, and cholesterol are too large and too hydrophobic. These products clusters together with the bile salts to form a new structure called a micelle. A micelle is a tiny water-soluble spherical particles. The bile salt creates a shell allowing the lipids to be transported through the watery digestive juices to the edge of the absorptive cell, the enterocytes. Once at the cell wall, the lipid diffuse out the micelle and into the absorptive cell. Here's the final case steps. Once inside the absorptive cell, the monoglyceride and longer chain fatty acids are reassembled back into the triglyceride. These brand new triglyceride, along with cholesterol and phospholipids, are then packaged into a special transport particles called a chylomicrons. This chylomicrons is the body's solution to the transport problem. Let's see how it works in the next slide. So chylomicrons, a type of lipoprotein, are coated with protein and phospholipids. So our intestinal cells has just built this particle that called chylomicrons. Uh, a chylomicrons is a type of lipoprotein, literally a particle of lipids again and protein, designed to transport fats in the watery blood. It's essentially a large sphere of reassembled triglyceride and cholesterol on the inside, coated with a thin layer of protein and phospholipids on the outside. This coating makes the entire particle water soluble. So the chylomicron is huge in molecular scale. It's far too large to fit into a tiny blood capillaries inside the villus. So it has to take different exits. It enters the lacteal, which is the larger lymphatic system, vessels located in the center of each villus. From there, the lymphatic system transports the chylomicrons all the way up the thoracic duct in the chest where they are finally dumped into the bloodstream via the left subclavian vein. Once the blood, an enzyme in the capillary wall called lipoprotein lipase, LPL, it breaks down the triglyceride inside them and releases the fatty acids for nearby cells, like muscles or adipose cells, to grab and use the entry or storage. So the chylomicron is just one of four major lipoprotein our body uses to transport fat. Let's meet the other three. The four key players in lipid transport, think of them as different types of delivery tracks for fat and cholesterol. The first one, as I mentioned, chylomicrons. As we just learned, these are formed in the small intestine, enterocytes. Their job is to transport dietary fat, the fat we just ate, from the GIT to the rest of the body. The second, VLDL, very low density lipoprotein. VLDL are made in the liver. Their job is to carry triglyceride that the liver has made out to the body's tissue. Number three, LDL, low density lipoprotein. LDL is what's left over from VLDL after it has delivered most of its triglyceride. LDL is now mostly cholesterol. Its job is to transport that cholesterol to the tissue that need it. This is why it's often called bad cholesterol, because it's the delivery track dropping cholesterol off in our tissue, including our artery walls. The last, the number 4, HDL, means high density lipoprotein. HDL are essential protein shell released from the liver. Also, they do the opposite of LDL. They perform reverse cholesterol transport. They circulate through the body, pick up excess water from the tissue, and brings it back to the liver for recycling or disposal. This is why HDL called good cholesterol. The differences in their jobs are directly reflected in their composition, as we see in the next slide. This figure provides a fantastic comparison of what each lipoprotein is made of. Look at the pie chart. The green, the green wedge is a triglyceride, and the blue is cholesterol. Look at the chylomicrons. As we discussed, it almost all triglyceride, 80%, 80% to 90%. It's just a massive fat delivery particle. The VLDL is also mostly triglyceride, about 55 to 65 percent is the VLDL, which makes sense as its primary job is also to deliver triglyceride. Now look at the LDL. After VLDL dropped off its fat, it becomes an LDL, which is 45% cholesterol. It is a cholesterol delivery particle. Finally, look at the HDL. Its composition is completely different. It is the high density lipoprotein because about 45 to 50 protein. The orange wedge is the protein. Before we leave the digestive system, let's quickly re- uh, revisit bile and what happens when that system goes wrong. Our body is very efficient and hates to waste. About 98% of the bile salt released into the intestine are reabsorbed in the ileum and travel back to the liver to be reused. This recycling process is called enterohepatic circulation. We can actually interrupt this. Soluble fiber in our diet, from oats, from beans, etc., can bind to the bile in the intestine and prevent its reabsorption. The bile and the fiber is then excreted in our feces. This is a good thing of cholesterol levels because it forces the liver to pull more cholesterol from the blood to make new bile, which helps lower blood cholesterol. Now, a common problem with this system is the gallstone. These are hard particles made primary of cholesterol that can form in the gallbladder. Again, gallstone are hard particles made primarily of cholesterol that can form in the gallbladder. If they cause a blockage or severe pain, means gallbladder attacks, a surgical procedure called cholecystectomy or gallbladder removal is often necessary. What happens then? Without gallbladder to store and concentrate bile just drips slowly from the liver into the intestine. This means the person loses ability to release large amount of bile in response to the high fat meal. The result is that the fat is poorly digested and passes into the feces. This condition is known as steatorrhea, the presence of undigested lipids in the stool. Lipid consumption patterns. So, how the average people doing in terms of fat intake? According to the statistics in the United States, from 2017 to 2020 data, the average American consumes approximately 37% of their totally daily energy from fat. So please search the data in your country if available and compare it. How does this compare to the recommendation? The acceptable macronutrient distribution range the AMDR for the total fat is about 20 to 35% of the total calories. So at 37 average of the American eating more than the recommended upper limit. The 2020 to 2025 dietary guidelines get more specific. They recommended that saturated fats be kept to less than 10% of the total calories. The average American intake is about 12%, so we are also exceeding this crucial recommendation. The guidelines also state that the trans fat and cholesterol intake should be kept as low as possible while consuming a healthy diet. In the next slide, I will show you the table that provides a clear, consolidated summary of all these official dietary recommendations. Look to this table. This is a great summary slide of the current dietary recommendation. This is what we should be advising our patient and the clients. Let's go through them. For the total fat, here, the AMDR is 20 to 35% of the total calories. For 2000 kilocalorie diet, that's about 45 to 75 grams per day. For saturated fats, the recommendation is strict, less than 10% of the total calorie. On that 2000 kilocalorie diet, that's max of 22 grams. For the essential fatty acids like linoleic acids, the omega-6 should be 5 to 10% of the calorie, and alpha linolenic acids omega-3 should be 0.6 to 1.2% of the total calorie. Finally, the cholesterol and trans fat, the recommendation is simple: keep intake as low as possible. We have seen the recommendation, and you know that many people are not meeting them. Lipids and the cardiovascular disease, CVD. CVD is a broad group of diseases that reflect heart and blood vessels. This includes heart disease, coronary artery disease, and stroke. In 2020, heart disease and stroke together accounted about a quarter, about 25% of all deaths in the United States. Most cases Most cases of the cardiovascular disease are end result of long-term chronic process called atherosclerosis. Let's break down that word atherosclerosis. Athero means lipid containing, and sclerosis means hardening. Atherosclerosis is the process where plaque, which is fatty buildup, forms and accumulate inside the arterial wall. This plaque built up in turn cause atherosclerosis, which is the hardening of the arteries. This means the arteries lose their normal flexibility and becomes stiff, which release the blood pressure and makes it harder of the blood to flow. Let's look at the step-by-step progression of how this plaque actually develops in the artery. So, how atherosclerosis develops? Atherosclerosis doesn't happen overnight. It's a chronic process, often begins in adolescence and starts with an injury. It all begins when the smooth, healthy lining of an artery gets injured. This injury can be caused by many things: oxidation, maybe infection, nutrient deficiencies, or as well, uh, you can see the constant of physical stress of the high blood pressure. The body immune system respond also with this injury by the inflammation. As a part of this inflammatory response, white blood cells are sent to the site. These cells, in an attempt to repair the damage, begin to deposit cholesterol and other substances just under the lining. This collection of cholesterol cells and other debris is what form the arterial plaque. This plaque is dangerous of the two reasons. The first reason, it grows and narrows the lumen or opening of the artery, and the second reason is it roughens the normally smooth surface of the artery, which slow down blood flow and creates a snag point, making it much more likely for a blood clot to form. The next figure I will show you, and to be clear, the four step that I mentioned, the entire process from a healthy artery to a blocked one. This figure is a perfect of the progression that give us the details, the progression of this disease. The step one, we have a healthy artery. Notice the smooth lining and the wide open lumen for easy blood flow. The step two, irritation to the lining has occurred. In response, cells have begun to deposit cholesterol under the lining, and you can see the initial information of arterial plaque. Step 3. This plaque has grown significantly. It's now roughening the surface and starting to narrow the channel, which slow down the blood flow and makes clotting more likely. And finally, in the step 4, we see the critical events: blood clotting. Blood clots, blood clot has become lodged on the rough plaque, becoming wedged in the narrowed lumen and flow, blocking blood flow completely. This blockage, as you can imagine, is what leads to the life-threatening consequences of the cardiovascular disease. So what happens when that clot, which we call thrombus, it blocks an artery? A thrombus is a fixed bunch of clots that stays in one place and disrupt blood flow. If this thrombus completely blocks an artery that supplies to the heart muscles, that section of the heart muscle is starved of oxygen and dies. This is a myocardial infarction, which we commonly call heart attack. If the exact same events happens in the artery in the brain, a clot blocks blood flow and the brain cells die, we call it a stroke. There's one more term to know: embolus. This is when a thrombus, when when thrombus or even a piece of a plaque itself break free and travel through the bloodstream. This embolus can then get stuck in a smaller artery downstream, causing the exact same devastating consequences: a heart attack or stroke, just in a different location. This entire atherosclerotic process is heavily influenced by risk factor. One, the most important, is hypertension or high blood pressure. Let's look at the two specific chemical and physical risk factor. Because what is the risk factor? Hypertension and homocysteine. Hypertension or high blood pressure is a major modifiable risk factor for the cardiovascular disease. It's a viscous cycle. Atherosclerosis makes arteries stiff and narrow, which rise blood pressure. In turn, that elevated blood pressure itself causes more physical injury to the arterial wall, which accelerate the atherosclerosis. It's often called silent disease because people with it frequently feel healthy, but it's very serious. The another risk factor that has been studied is homocysteine. Homocysteine, this is a toxic byproduct of the normal protein metabolism. Normally, our cells use three vitamins: vitamin B6, folate, and vitamin B12 to convert homocysteine into safer compound. But some people have genetic condition called homocysteinuria that causes homocysteine to accumulate in the blood. It's thought that these high levels may injure the arterial walls, thus increasing cardiovascular disease risk. So hypertension is just one of many risk factors. In the next table, I will show you and summarize all the measures. One. This table divides the major risk factor for atherosclerosis into two distinct groups. First, we have the non-modifiable risk factors. These are the ones you are stuck with. You cannot change them. They include your family history of cardiovascular disease, I mean genetics. Advanced age, risk increase as you get older. Male sex, males are more likely to have heart attack than female. And your race or ethnic background. The second, and more importantly for us as health professionals, are the modifiable risk factors. These are that ones you can change primarily through lifestyle. This list includes diabetes mellitus, a poor diet, elevated blood cholesterol, especially LDL cholesterol, excess body fat, hypertension, physical inactivity, and tobacco use, and also untreated sleep apnea. So, lipoprotein and atherosclerosis. I will be in detail in this figure. This figure beautifully uh, beautifully explains the good versus bad cholesterol concept at the artery wall level. As we learned, LDL is the bad cholesterol. Its job is to transport cholesterol to the cells for their use. The problem is when there is too much of LDL. It can also transport cholesterol into the arterial lining, especially at the site of injury. This is especially true for oxidized LDL. When LDL particles are damaged by free radicals, a process called oxidation, they more easily taken up by the immune cell in the artery. These immune cells gorge them into the oxidized LDL and become foam cell. These foam cells are the foundation of atherosclerotic plaque. On the other hand, HDL is the good cholesterol. Its job to perform reverse cholesterol transport. It circulates transport cholesterol away from the body cells, including from those foam cells in the arterial wall, and takes it back to the liver for disposal. So high density or so high LDL is risk and high HDL is protective. So given these complex rules, how do we get a clear picture of a person's risk? We use blood test called lipoprotein profile. So to determine person's risk, we can't just look at their total cholesterol. We need a full lipoprotein profile. This is a specific series of blood tests, ideally done after 9 to 12 hours fast, that measures four key things: total cholesterol, LDL cholesterol, HDL cholesterol, and triglyceride. Looking at the cholesterol alone can be very misleading. For example, a young male could have desirable total cholesterol of 180 milligram per deciliter. But if his good HDL is only 30 milligram per deciliter, his risk is actually high. A more useful metric is the total cholesterol to HDL ratio. A healthy ratio is less than 3.5 to 1. That 180 divided by 30 example give a ratio 6 to 1, which is very high risk. We can also measure high sensitivity C-reactive protein. Since we know atherosclerosis is an inflammatory process, the liver responds to this inflammation by producing CRP. An elevated CRP is a biomarker that indicates heightened state of inflammation and increased risk of cardiovascular disease. The next table gives us the standard classification. This table is essential for interpreting labs result. These are the classification of for fasting blood lipids in adults. Let's go through this. For the total cholesterol, we want to see it desirable, which is less than 200 milligram per deciliter. 240 is or more is considered high. For LDL cholesterol, the bad one, the goal is optimal, which is less than 100 milligram per deciliter. 160 or more is high, and 190 or more is very high. For HDL cholesterol, the good one, we want it high. A low or poor level is less than 40 for males or less than 50 for females. We want to see it at or above those levels. Finally, the triglyceride normal is less than 150 milligram per deciliter because 200 or more is considered high. Now, think back to our think back if the patient LDL is 140. LDL is 140. So we backed here. LDL is 140 is here in this range. So that means the borderline. And if the HDL is 35, 35 is less than, if it is male, less than 40. This is why here, why this person or his risk is high. This is as example. This is where we apply our knowledge to make practical dietary intervention. So reducing risk by dietary changes. Different types of fats have very different effects on our blood lipids. Saturated fats, diet rich in saturated fats, are linked to higher rate of cardiovascular disease. They tend to alter liver cell membranes, making the liver less effective at removing cholesterol from the blood. As a result, most saturated fatty acids rise the total blood cholesterol, including both LDL and HDL level. Trans fat, these also rise blood cholesterol level and should be limited as much as possible. The monounsaturated fatty acid, these are beneficial. They generally lower the bad LDL cholesterol without reducing the good HDL cholesterol. While the polyunsaturated fatty acids, these are also tend to reduce total cholesterol and bad cholesterol. In some people, they may also slightly reduce beneficial HDL, but they are still considered healthful. The key takeaway and the official recommendation is to replace food that are rich sources of saturated fats and trans fats with foods that contain greater percentages of monounsaturated and polyunsaturated fats. Let's look more closely at the two types of polyunsaturated fats as their effects are not the same. So, reducing the risk, omega-6 versus omega-3. There are an important distinction between the two essential polyunsaturated omega-6 and omega-3. Omega-6, linoleic acids. The typical American diet is very high in omega-6, and also here in my country, which comes from common vegetable oils like sunflower oil, like corn oil, soybean oil, and as we learned, our body convert omega-6 into arachidonic acid, which in turn produces icosanoid that tend to increase inflammation and promote blood clotting. Some inflammation and clotting is necessary, of course, but having blood that clots too readily can increase the risk of heart attack and stroke. On the other hand, omega 3, eicosapentaenoic acid and docosahexaenoic acid, in contrast, eating food that supply omega 3 fatty acids reduce the risk of developing heart disease. Their eicosanoids tend to be anti-inflammatory and reduce blood clotting. The clear recommendation from 2020 to 2025 dietary guidelines is to consume at least 8 ounces of seafood, especially fatty fish like salmon, tuna, sardine per week to get these beneficial long chain omega 3 fatty acid. So, omega 3 benefits and sources. First, let's look at the possible health benefits. Beyond the well established reduced risk of heart disease, research suggests omega 3 may also reduce the risk of arthritis, certain cancers, and Alzheimer's disease, and depression. They are also thought to improve immune function and are critical for cognitive development in infants. In this table shows the rich food sources. The best source of the most active forms, docosahexaenoic acids and eicosapentaenoic acids, are fish and shellfish, specifically fatty fish like salmon, like tuna, like sardine. You can get the precursor of alpha linolenic acid from plant sources like flaxseed and walnut, and their respective oils: flaxseed, walnut, canola, and soybean oil. We have focused on replacing bad fats with good fat. But what about other dietary modification, like reducing dietary cholesterol or increasing fiber? So, reducing risk by the other dietary modification. Let's cover a few other important dietary modifications that can help lower cardiovascular risk. What about dietary cholesterol? For decades, we told people to avoid egg yolks. However, studies now suggest that for most healthy people, dietary cholesterol doesn't have a much of an effect on blood cholesterol as dietary saturated fat does. The reason appears to be that the liver has a feedback mechanism. In a healthy person, when dietary cholesterol intake is high, the liver synthesizes less cholesterol to compensate. Saturated fat, on the other hand, seems to override this and increases the liver's cholesterol production. Increase soluble fibers. This is a key recommendation as we learned in the last chapter. Soluble fiber from oats, barley, bean, and fruits can significantly reduces the LDL cholesterol level, largely by binding to bile and forcing its excretion. For high triglyceride, more than 150 mg per deciliter, if a person's triglycerides are high, the primary uh, culprits are often not fat, but refined carbohydrates, like reducing intake, like candy, pastries, sugar-sweetened soft drinks, and alcohol. Should be reducing intake of these can dramatically lower the triglyceride level. So, food selection and preparation. This is simple, practical advice. Limit processed and cured meats. Trim visible fat from meats. Use cooking methods that do not add fats like steaming, or use small amounts of healthy oils like in stir frying, and be aware of the hidden fats in food like cheese, fried foods, and dressing. Finally, let's talk about the non-dietary lifestyle changes and what to do if these lifestyle modifications are not enough. Diet is only one part of the puzzle. We must also address lifestyle factors, especially activity and weight. Excess body fat, especially around the midsection, is strongly associated with unhealthy blood LDL and triglyceride level. Therefore, weight loss, if a person has excess body fat, is a primary goal. A key component of this is physical activity. Engaging in regular physical activity, the recommendation is at least 150 minutes per week of moderate intensity activity has multiple benefits for blood lipids. It can help reducing bad LDL levels, reduce triglyceride levels, and very importantly, it is one of the most effective way to rise your good HDL level. For some people, especially those with a strong genetic predisposition, these lifestyle changes are not enough to get their blood lipids into a healthy range. In that case, a healthcare providers may prescribe medications. The most class of the drugs is statin. Statins work by interfering with the liver's production of cholesterol, which effectively lowers LDL cholesterol and to some extent triglyceride level. Another drug, Zetia, the trademark, works differently. It inhibits intestinal absorption of cholesterol. This brings us to the end of our chapter. Let's do a quick high-level summary. So let's briefly review the key concept from chapter 5, the part 2. We learned that there are three main classes of lipids: triglyceride, which provide energy; phospholipids, which form a cell membrane; and sterols, like cholesterol, used membrane, and hormones. We defined the different fatty acids: saturated fatty acids and monounsaturated fatty acids, which includes the essential omega-3. We also identified the trans fatty acids as a product of hydrogenation. We followed the complex path of lipid digestion, which requires bile from gallbladder for emulsification and pancreatic lipase for breakdown. Where we then saw how lipids transported using lipoprotein, starting with chylomicrons delivering dietary fats, and then focusing on the critical balance between LDL, the bad cholesterol transporter, and HDL, the good cholesterol collectors. Finally, we linked these concepts directly to cardiovascular disease, showing how high LDL contributes to atherosclerosis. and we outlined the key strategies to reduce risk, replacing saturated and trans fat with monounsaturated and polyunsaturated fats, increasing soluble fiber, losing excess weight, and engaging in regular physical activity. Thank you. That concludes our lecture on lipids. I will see you all the next time when we will move on to our next macronutrients, protein. Thank you and goodbye.